So let's talk about pre-eclampsia. So, what is pre-eclampsia? In basic words, pre-eclampsia is when the mother during pregnancy gets hypertensive. And there's a lot of reasons why that happens. So let's go all through that and give you a good understanding of what exactly pre-eclampsia is. All right. So what causes preeclampsia? What is the etiology of preeclampsia? Number one is an abnormal placenta. And what does that even mean, man? Like, what does abnormal placenta mean? We'll get into that. But basically, it's a placenta that is kind of not normal, obviously. Number two are there's risk factors that can increase the chance of a mother getting preeclampsia. So, what are those risk factors? Number one is their first pregnancy. So, if it's a mother's first pregnancy, they're at a higher chance of getting preeclampsia. Number two, multiple gestation. What I mean by that is, if they have twins or triplets, stuff like that, that increases the chance. Number three, if they already have, chronic hypertension, that increases, and that kind of makes sense. Previous history of diabetes and obesity, and previous episodes of preeclampsia with previous pregnancies. That all makes sense. But okay, now that we know, what causes it, what is the pathophysiology, and that's what we like to focus on this channel. Is what is the pathophysiology of preeclampsia? So basically, um, what it is thromboblasts fail to remodel spiral arteries. So, what exactly even is that? So, when you have your placenta, let's just say, this is your kind of placenta over here, right? And then, you have your placental veins and arteries that is then feeding onto the baby, correct? Now, the actual arteries that are actually feeding into the placenta, right? The end arteries, so like the arteries at the very end that actually feed into the placenta are called spiral arteries, and there's multiple. There's many of them that all connect to the placenta. Now, basically, thromboblasts, so these are the cells, when you kind of have the baby, the very precursor cells, when you have that kind of cell happening. Um, Thromboblasts will actually want to remodel these spiral arteries. And what they do exactly is, this is, let's say this is your placenta, that's your spiral arteries. Thromboblasts will come in, and what they want to do is make this dilated. So the spiral arteries tend to then end up looking like this. So they're a lot more dilated, right? And the reason being is you want more blood, you want more perfusion happening and kind of going into the placenta. So thromboblasts are responsible for doing that. But what happens in this case is thromboblasts actually fail to do this. Thromboblasts don't go in there and actually remodel the arteries to make them bigger. So what happens then? So these spiral arteries, they remain narrower, right? So they're going to be extremely narrow like this. They will be very high resistance as well, right? Because they're narrow, that makes sense. Blood is gonna be harder for blood to actually go through and go into their placenta. Right. So what happens then? Okay, what happens if you have less blood going to the placenta? Okay, well, it makes sense. You're going to have ischemia and hypoxia. So ischemia, you have less blood going into the placenta, and of course, since blood carries oxygen, you're having less oxygen going into the placenta. Right. Okay. Fair enough. What does that even mean? Okay, sure, you have that issue, but then what? So then what actually happens is the placenta starts becoming anti-angiogenic. Okay, what does that mean? Basically, it becomes kind of anti blood vessels. All right. Um, what does that mean again? Basically, what it does, it's going to release these factors, and I don't think it's really important to memorize these factors. But what these factors actually do is these factors will come in and start affecting and inactivating VEGF and PIGF. So these are, I believe this is your vasoendothelial, and then this is your placental growth factors. And what it will do here is start inactivating them, and this is what we kind of need for a healthy endothelium. So endothelium meaning the cells that kind of make up the vessels, right? So basically, if you have your blood vessels, these cells, the endothelial cells, they kind of line the interior of your blood vessels, and it's going to start affecting them. So what do they end up doing? Basically, when you restrict VEGF and PIGF, what happens is the endothelium is going to become vasoconstricted. So it's definitely going to become smaller. They're going to become leaky. So instead of like a normal kind of blood vessel here, it's going to become more like this. You're going to have a lot of leak, a lot of space for things to get out, especially water, which we will kind of delve into what that means, and prothrombotic. So prothrombic, right? Basically, you have a lot of thrombocytes forming. You have a lot of platelets kind of clotting here. As you can see, that would be a big issue because now it's blocking the vessels. It's making it harder for red blood cells and other cells to actually go past this, right? So that is what happens um, in this situation. Okay. So now all this happens. What are the actual symptoms that the person is going to experience or the mother is going to experience? So let's divide the symptoms into kind of three parts. So let's just go back into the clinical features and just divide into three parts. You have your vasoconstriction. So as I said, when you have inhibition. So when you have inhibition back here, um, of the VEGF and PIGF, what's going to happen? You're going to get vasoconstriction of blood vessels. You're going to get leaky endothelium. It's going to become more leaky, as we said, and it becomes prothrombotic. And all of these will cause effects. So these are going to have end organ effects and effects across the body. Now, okay, let's delve into this real quickly. So vasoconstriction, you can imagine if the blood vessel is now smaller, there's going to be hypertension. The body person's going to have hypertensive, and that's the main thing we see in preeclampsia is the mother is hypertensive, right? Now into the brain. Now, if you have vasoconstriction in the brain, right, perfusion is going to be an issue. There's not going to be consistent perfusion, and this alongside it being leaky, with the being vasoconstrictive or having less blood in the brain, and also becoming having cerebral edema, as we can see here. What that kind of leads to is headaches and visual disturbances, right? The blood supply to the brain is being restricted, it's making it difficult, it's inconsistent, and the brain will show that as headaches and visual disturbances. You're going to have liver ischemia. Liver is very sensitive to changes in blood perfusion. So if you have lower blood perfusion, it's going to cause it's going to cause liver damage, right? And what you're going to see then, if you have liver damage, you're going to see increased LFTs, right? Liver function tests are going to increase, and you're going to get right upper quadrant pain as well. And that's because it causes swelling, right? It's going to cause swelling of the liver, which will then cause this right upper quadrant pain, which is also very, very common. And then renal perfusion. This is again a very, very common thing. Is now you have less blood supply to the brain, to the renal, to the kidneys, and you're getting oliguria, so you're going to get less urine output, and you're going to get more creatinine, right? And that all makes sense. And then one thing we don't want to forget is placenta. So we don't want to forget about the baby, right? So what's going to happen to the baby? Well, the baby is now, because the placenta, right, the placenta is becoming hyperperfused, it makes sense the baby will be receiving less blood, right? It makes sense the baby will now be receiving less blood, right? And so what happens to the baby? The baby is going to be hypoxic. He's not getting enough oxygen due to the lack of blood, and also we're going to see a growth restriction. Why? Because not getting enough nutrients from the placenta, struggling. That's what we commonly see with preeclampsia. Now, if you go into the leaky endothelium, when you have leakiness, right? So you have all these little leakiness. Okay, so what's going to happen here? Well, what's going to happen here is you're going to have water. You're going to have water escape through these leakiness, right? And also because we have proteinuria in the kidney, because of the leaky endothelium, you're going to get more proteinuria. So there's increased amount of protein in the kidney. And what does that mean? There's less protein in the blood. And because now, if you remember osmotic pressures, you have less protein, there's less kind of attraction for the water to stay in the blood vessels. They're going to start escaping. So what do you get? You get edema. So you're going to get facial edema, body edema everywhere. You're going to get swelling. More specifically, you're going to get pulmonary edema as well. So more, and also cerebral edema. Now this is when you can get seizures, and seizures is a thing that differentiates preeclampsia. So that's what differentiates preeclampsia from clampsia. Remember that, right? It's the presence of seizures that's what's going to kind of cause that difference. And we were discussed proteinuria in the kidney. And the other thing is prothrombic state. So it kind of causes, it does cause brain seizures as well, alongside the leaky endothelium. My apologies, I cannot pronounce the word seizure, so we can just ignore the fact that I can't pronounce it. But it causes something called HELP syndrome. So what is HELP syndrome? So let's delve into this. So basically, if you imagine a blood vessel over here, That's a normal blood vessel. But now, because we're in a prothrombotic state or prothrombic state, you can have all these clusters of platelets and platelet plugs that kind of form here. And now, what you can imagine is eventually, when you have red blood cells traveling, one of them is going to just smash into this, right? And it's going to destroy that red blood cell. And so, what would we call that? We call that hemolysis, right? So it's going to be um, hemolysis or increased hemolysis of red blood cells. But not only that, you're going to also see, as we discussed before, you're going to see increased liver enzymes, correct? Increased LFT. So what does HELP stand for? HELLP. This stands for hemolysis, okay? And this stands for elevated liver enzymes and low platelets. Right? And that makes sense. So hemolysis, because as we discussed, the red blood cells are kind of hitting the platelet plugs, so you're going to have hemolysis. You're going to have elevated liver enzymes. Why? Because we discussed before, you're going to have liver damage, right? We have less blood supply to liver, so you're going to elevated liver enzymes and low platelets because, well, they're getting used up. They're getting used up making the thrombotic plugs, so they're not going to be as many platelets when you do a blood test. Makes sense. So those are the kind of the clinical features you're going to get very commonly with preeclampsia. Now, how do you actually diagnose preeclampsia? So we discussed before, the number one thing you need is number one is hypertension. They must be in hypertensive, right? Or hypertension episode. So what does that mean? That means that they have systolic 140, diastolic 90. So they have over 140 slash 90 as their blood pressure. Usually it must happen after 20 weeks of gestation, so 20 weeks gestation. It can actually happen after the baby is born as well, up to 6 weeks. There's also a chance you get preeclampsia after birth as well. And it should be hypertensive on 2 readings as well. Okay, and alongside the hypertension, they can have either one of the following. They can either have number 2, proteinuria, so you have over so greater than 300 over 24 hours of milligrams of protein, or a PCR that's greater than 30, which is protein to creatinine ratio. Again, because you can have proteinuria, PCR is going to increase, right? Or you can have signs of end organ dysfunction, as we discussed here before. So, if you have oliguria, increased creatinine, headaches, visual disturbances, you can have pulmonary edema, cerebral edema. So if you have signs of that, that's what classifies as a diagnosis for preeclampsia. So either you definitely need hypertension and either or proteinuria or end organ dysfunction signs. So in terms of treatment, if you move back now to treatment, number one, you want to monitor, you want to look at the BPs, look at the urine output, do their blood tests, right? And if they're, it's moderate or mild immune disease, you want to admit them. And then number two, this is only when there's a chance of this severe preeclampsia, or there's a chance it already is into eclampsia. You're going to give magnesium sulfate. Why? This is because to prevent any seizures from happening. So once you get the seizures, they're going to be into eclampsia instead of preeclampsia, right? So sometimes if it's a severe preeclampsia episode, we give prophylaxis, but if it's not, they usually don't tend to. Again, number three, control blood pressure. That makes sense. And the main priority for this is actually to avoid complications such as if they get a cerebral hemorrhage from the increased blood pressure. So you want to control their blood pressure, not to get it back down to the normal, which pretty much is very difficult, but to ensure that complications like a hemorrhage will not happen. So usually they use, labetalol as their first line. And of course, you want to monitor the fetal. It's very important. We don't want to forget about the fetus and the baby, right? So you want to do a CTG and you do an ultrasound. So, growth and a Doppler ultrasound on the baby just to monitor the baby, make sure that the fetus is doing okay. And then, of course, these are all management, right? These are not going to really treat it. The only definitive treatment is you do the delivery. And this makes sense because when you do the delivery, the placenta will release and all the anti-angiogenic effects of the placenta will then leave, right? So that's what you want to do. Now, this is it's of course it kind of depends on a case by case basis of how severe it is, and usually doctors will meet up and with all the other health professionals and decide. But usually the kind of logic is, if it's a mild preeclampsia and the mother is less than 37 weeks, you do not want to deliver. You want to because you want to balance out the effects of a premature birth with the effects on the mother, right? So less than 37 weeks, usually we just monitor and wait. But if it's greater than 37 weeks, we go and deliver. If it's severe, and they're greater than 34 weeks, we usually tend to just deliver. If they're less than 34 weeks but stable, we try to monitor and sort of stabilize the person. But if they're less than 34 weeks and they're unstable, there tends to be delivery that happens in order to save the mother. So in terms of, in this situation, the thinking process is the risk associated with prematurity are not as great as the risk to the mother if they were not to deliver. So basically, that's it. That's the summary of preeclampsia. Hope that was helpful. Thank you.